Hello guys, welcome to our channel. Today we are going to discuss about the rapid revision of the medicine third part as part of our mission to 100 place. So we are going to complete this with the important topics. So in this I'm going to include the endocrine guys and also neurology, GIT and then hematology. Okay, these topics we are going to cover this in this session guys. So those who haven't watched the previous part 1 and part 2, please do watch, and all these importantly the first topic, second topic, in these three parts now I'm expecting at least 20 MCQs in the upcoming examination guys. So please make sure that you are going to watch these videos before you are going to the examination. Okay, so let's start the discussion. First, here we are going to discuss about the headaches. Okay, so when I say headache, the most important point about the headache, what is the most common cause? So the most common cause will be the secondary type of the headache. So in the secondary type, what could be the cause? Acute febrile illness. Okay, acute febrile illness is a common cause for that the patient will be suffering from the headaches. Next, these are going to be the primary types of the headaches. So in the primary types of the headache, what is the most common? Again, it is tension type of the headache is the most common, then migraine, and cluster is very least type of the headache. So let's see the discussion of the tension type of the headache. So tension type of the headache is most commonly seen in the females. And what is the age? Usually about 20 to 30 years of the age people will be experiencing from the tension headache. And how the pattern will be? The bilateral headache will be on the both sides of the temporal region and band like sensation, okay, on the forehead, and throbbing kind of pain the patient will be experiencing. And what is the duration? Duration will be hours to days. Hours to days the patient will be experiencing. What could be the aggravating factors? For example, stress, okay, divorce, family issues, friends, breakup, all this will be associated with the aggravating factors. Next, what could be the drug of the choice for this patient? We can give the NSAIDs, acetaminophen or the naproxen. These NSAIDs can be given. Whatever the prevention of this headache, guys, for the prevention of the headache, we can go for the antidepressants. Okay, like amitriptyline, we can give this patient for at least 3 months, right? Next, moving on to the migraine type of the headache. Migraine type of the headache, again, it is commonly seen in the females. Okay, most of the femaleness will be associated with the migraine. Next, age will be say 20s to 40 years of the age commonly seen. And headache pattern will be unilateral, okay, pulsatile, unilateral, pulsatile with throbbing headache, but migraine will be associated with the aura. So what does mean by the aura, guys? Usually the patient will be experiencing the nausea, vomiting, and also photophobia. Okay, so what about the classical or the non-classical? So if they are associated with aura, then this migraine is known as a classical. But most commonly, we are going to see the non-classical only. That non-classical type of the headache will be no aura. Okay, no aura will be present in this type of headache. And what is the duration? Usually it will be 6 hours to 72 hours. 6 hours to 72 hours duration will be seen. What are the aggravating factors? Age, okay, and femaleness, and also genetics, those who are associated with the genetics, and NO associated foods, okay, nitric oxide foods, OCPs, and low anxieties, okay, low anxiety, overthinking, this will be associated with the migraine. What is the drug of the choice patient? Drug of the choice for this patient, guys? Sumatriptan. Okay, sumatriptans, this is the drug of the choice. Next, what is the prevention then? So prevention drug of the choice is propranolol. Propranolol is the drug of the choice for this patient, right? But what are the other drugs that we can give, guys? For example, topiramate can be given for this patient, and also fluma or flunarizole can be given. Candesartan, okay, candesartan drug can be given, and venlafaxine and botulinum. Okay, these drugs can be given for this patient. Next, moving on to the last type of the headache, cluster type of the headache. So cluster is associated with the very least common, okay, and mostly this is opposite to that. Mostly males are associated with this pain, and it is unilateral, okay, unilateral, and only specific region will be associated with the pain. only specific region. What are the aggravating factors? Age, season, okay, alcohol, cold. These are the aggravating factors. Other symptoms also associated here. The patient will be having the rhinorrhea, congestion, redness of eye. That will be seen. Whatever the duration, guys, usually it will be lasting 30 minutes to 1 hour. Okay, only 30 minutes to 1 hour. So in this period, what is the treatment of the choice? This is the PYQ, oxygen therapy. Okay, oxygen therapy 10 to 12 liters per minute we can give. Next, whatever the prevention, for the prevention, we can go for the steroids as a drug of the choice. Okay, this is how we are going to treat the migraine, tension headache, and the cluster headache. Next, here you can see this is the picture that we are seeing the Broca's area and the Wernicke's area. So let's discuss the difference between the Broca's and Wernicke's. Okay, let's see. First, coming to the Broca's area, guys. Where is the Broca's area is presented here? Here you can see. This is the gyrus, that is the differentiating between the whatever the temporal and the frontal lobes. So where is the Broca's area is presented? It is present at the inferior frontal lobe, right? Next, whatever the Wernicke's, it is present at the superior temporal. Superior temporal. What is the artery that is involved here? Usually what happens, there is a artery that is coming here is known as a MCA territory. So MCA that is coming the downwards is going to be your inferior and going upward is superior. So the artery that is supplying here is the superior MCA and here it is inferior MCA. Inferior MCA artery is going to be produced. Next, Brodmann's area. What is the Brodmann's area here? 44 and 45. Here, the Brodmann's area is 22. Next, important points about the Broca's aphasia and the Wernicke's aphasia. So when I say aphasia, those who are suffering from the Broca's will be having the non-fluent aphasia. Okay, so it is associated with the non-fluent aphasia. That means the patient is associated with the non-fluent. His motor ability will be involved. Along with that, the patient will be using the different, okay, different answers and unable to recall. Okay, non-fluent aphasia. So the words will be blabbering, okay, blabbering, hiccups, pauses that will be seen in the patients of the Broca's. Here it is fluent aphasia. Fluent aphasia. So motor involvement is not seen here, but they use new words. Okay, new words such as neoglossism will be seen here, and also word salad. Very random words they are going to use. That is seen in the patients of the Wernicke's aphasia. Next, coming to the naming will not be seen, and also repetition is not seen. Here also, patient will be not naming anything and no repetition as well. Next, among all the aphasias, what is the most common? The most common will be anomic aphasia. Okay, and what is the cause for this patient? Usually post-trauma. The patient, those who are suffering from the severe post-head trauma, there will be associated with the anomic aphasia, right? Next, moving on to the another important topic, guys. So that is known as a subdural hematoma and the epidural hematoma. Okay, now in the subdural epidural, first thing that you have to remember, epidural hematoma is due to most commonly middle meningeal artery. Okay, middle meningeal artery. Next, SDH. SDH is due to bridging veins. And these patients, those who are with the EDH, will be consisting of lucid interval. Okay, lucid interval. And here no lucid interval is seen. So what is meant by the lucid interval? For example, here you can see the lucid interval the patient will be having the loss of consciousness immediately after the event. A patient will be gaining the conscious after 1 hour. Okay, then again after 2 hours, let's say, or 1 hour, the patient will be having the loss of consciousness. And next episode, if they lost the consciousness, there will be a death. That is known as a lucid interval for the differentiation of the epidural hematoma. Next, for this patients, what is the investigation of the choice? NCCT. Here also investigation of the choice is NCCT. On the NCCT, what is the finding that you are going to see? This is known as a crescent. This is known as a biconvex shape, right? This is biconvex shape. Okay, and here you can see this is the concave shape, concave or crescent shape, that is seen in the SDH. So S for sickle, S for SDH. And here like it is like a biconvex or the idli shaped, that is seen in the EDH and the SDH. Next, what is the treatment of the choice for this patient? Both patient, we are going to proceed for the craniotomy or burr hole. Here also craniotomy and burr hole. Okay. Next, SIA, subarachnoid hemorrhage. So what is the most common cause for the subarachnoid hemorrhage, guys? Berry aneurysms. Okay, berry aneurysms, and most commonly anterior communicating artery is involved. Anterior communicating artery that is involved in the patients of the SH. Most common cause will be due to, this is rupture. Okay, most common cause will be due to hypertension, that is seen in this patient. Investigation of the choice is NCCT, and treatment will be, okay, craniotomy or the burr hole surgeries, but it is within the subarachnoid region, right? So what for this patient, what we can do? Embolization we have to do. Okay, embolization is the treatment of the choice for this patients of the SH. Next, moving on to the important topic, stroke. Okay, so in this stroke, what you have to take note. First, remember that stroke is most commonly associated with what condition? The most common cause for these patients with a stroke is hypertension. Okay, it is due to hypertension. And along with that, the patient will be having the age factor. Okay, males and also those who are commonly associated with the diabetes mellitus, atrial fibrillation, right? And also genetic conditions like homocystinuria, Marfan syndrome patients will be associated with the patients of stroke. Next, stroke is divided into the another three types. Okay, first, transient ischemic attack, which will be less than 24 hours with warning signs. Okay, with warning signs. Next, ischemic attack. So this ischemic attack is only that there is a thrombus formation. And next, hemorrhagic attack. So hemorrhagic attack is going to be rupture of the vessel. Okay, rupture of the vessel. Next, what is the most common locations that is involved in these types? So ischemic type, most commonly it is going to involve the MCA territory, middle cerebral artery. Next, hemorrhagic artery, hemorrhagic stroke, it is going to involve the putamen. Okay, it is going to involve the putamen or the basal ganglia region. Okay, collaterals is going to be damaged. Next, you also have the criteria for this. Okay, what is the criteria? A, B, C, D, 2. Okay, D is going to be 2 times. What is this A, B, C, D? Age, the patient is more than 60 years of old and patient is having the blood pressure and clinical symptoms which will be visible in this patient, and diabetes mellitus, also the duration of the symptoms. Okay, duration of the symptoms will be also present in this condition. Next, this is the one score that you have to recall. Next, another score, here you can see this is B fast. What is mean by the B fast, guys? First, the patient is lost of the balance. Eyes, you are going to see nystagmus or the blurred vision. F for face, facial droopiness or the facial paralysis. A for arms, asymmetry, only one-sided paralysis, and speech difficulty and time. Immediately call the ambulance as soon as possible. Okay, all these symptoms that you have already seen in the patient. Next, what is the treatment that we have to proceed? So whenever you see the patient with a stroke or stroke-like symptoms, or patient with a history of bleeding, okay, patient with history of bleeding, what is the first thing that you have to do? Immediately you have to proceed for the NCCT. Okay, this is the initial diagnostic test. Okay, initial diagnostic test. And why this is important, guys? It is about to differentiate, is it the epidural, or is it the subdural or subarachnoid hemorrhage, or internal cranial hemorrhage. So these all differentiation will be done by the non-contrast CT scan. So if this is going to be negative, okay, if this is negative, then you have to proceed for the CT angiography. Okay, if it is positive, you are going to differentiate between the EDH, SDH, SIH. If it is negative, then you have to proceed for the CT angiography. Along with that diffusion weighted MRI, you can proceed. Okay, next, another treatment protocol, what we have to follow for this patient. So treatment protocol for the patients of the stroke. First, if the patient presentation time is very important. If the patient is less than 4.0 hours presented at our emergency medicine and no active bleed, it is just an ischemic attack, what you have to do. And if the patient is more than 18 years old and no blood pressure which is more than 200 mmHg, and no edema is present in the cerebral region, then upon these conditions you can proceed for the patient's thrombolysis. Okay, thrombolysis can be done for this patient, right? Next, another protocol, that the patient is less than 6 hours or within the 24 hours. Then for this patient, if the MCA territory, one third of MCA territory is involved, one third of MCA, less than one third of the MCA territory is only involved, then we can proceed for the mechanical thrombectomy. Mechanical thrombectomy, we can proceed, right? This is the another protocol that we can follow. But if the patient is more than 24 hours to 48 hours, okay, for this patient we have to go for the dual antiplatelet therapy, and physiotherapy. Okay, we cannot proceed for the any other treatment, right? This is the how you have to proceed for the stroke. But sometimes stroke is thrombolysis is contraindicated. Okay, thrombolysis is contraindicated. So in which patient we have to find out that thrombolysis is contraindicated, guys? Especially those who are having the bleeding disorders. Okay, bleeding disorders, or patient is already have the history of surgery, okay, less than 2 months, or patient is having the active pelvic inflammatory disease or the pelvic ulcer disease, patient is ongoing menses, also we are not going to proceed. And GI disease or the GI surgery, okay, GI surgery less than 21 days, or patient is more than one third of the ischemia is involved, major territory, and also blood pressure more than 185 to 200 mmHg, we are not going to proceed for the thrombolysis of this patient, right? This is how importance and protocols that you have to follow. Next, from this picture you can clearly understand what is this condition, guys. This is known as a Lambert-Eaton syndrome, and this is the myasthenia gravis. You have kept the lamb for them at dinner time. Okay, this is the dinner time. You have kept the lamb for them to eat. But the patient with the myasthenia gravis, very tired, he cannot eat. But Lambert-Eaton, very active and he want to eat. So what is the differentiation between these diseases? Let's see here. So this condition is presynaptic. Okay, and this condition is postsynaptic condition. So in the neurotransmission, myasthenia gravis is the postsynaptic and Lambert-Eaton is the presynaptic condition. So how the presentation will be presented, what is the condition that is due to? This is due to voltage gated calcium channels. This is due to voltage gated calcium channels, and this is due to acetylcholine receptors. This is due to acetylcholine receptors. Next, the symptoms will be the patient on the day time, they will be inactive. Okay, they will be inactive over the time, and by the time ending evening, they are going to be active. Okay, opposite to here. And the daytime they are going to be active, whereas night time this patient will be inactive. Why? Because acetylcholine receptors are already consumed. That is why they are not going to be active in the night times. Next, coming to the what are the associated conditions? The associated conditions will be lung cancer, especially small cell cancer, that is going to be involved here. Next, in this patient, the associated condition will be thymoma. Next, what is the drug of the choice for this patient? Lambert-Eaton syndrome is 3,4-diaminopyridine. Diaminopyridine is the drug of the choice for this patient. Next, here the drug of the choice patient is pyridostigmine. Okay, pyridostigmine is drug of the choice for this patient. Next, moving on to the only focus on the myasthenia gravis. Okay, myasthenia gravis is most common neuromuscular junction disorder. Okay, and this is associated with the females rather than the males. What is the hypersensitivity reaction that is associated here? Type 2 hypersensitivity reaction. Okay, sometimes it is also known as a type 5 hypersensitivity reaction. Next, how it is going to be prognosis? If the patient is having the females into 20 to 30 years of the age, then it is associated with the good prognosis. But males who is more than 50 to 60 years, then it is going to be bad prognosis of the disease. Next, what are the importance of this myasthenia gravis? 90% of the cases most commonly associated with the anti-ACH receptors is going to be involved, and followed by the 50% anti-muscarinic agents, anti-musk are agents, and then very rarely lipoprotein 4R is going to be involved here. Next, symptoms. First symptom will be ocular ptosis, and over the time it can involve all facial muscles also. Okay, all facial muscles will be involved for this patient. Next, what are the tests that we can apply for this patient? Tests that commonly done for this patient will be ice pack test, that we can go, and tensilon test. Okay, tensilon test also we can follow. For the tensilon test we are going to use hydrophonium we are going to use. Next, importantly, that you have to remember what is the specific test. Okay, the specific type of the test is antibodies. Next, sensitive test is the nerve fiber test. Nerve fiber test is the sensitive. Next, again, we already know the drug of the choice will be pyridostigmine is going to be used. Next, treatment, you can go for the majorly you can do thymectomy, and if it is a serious crisis, you can go for the plasmapheresis. That is a protocol that we are going to follow for the Lambert-Eaton and the myasthenia gravis. Next, we are going to discuss about the GBS. Okay, this is known as a Guillain-Barré syndrome. This Guillain-Barré syndrome is going to be acute autoimmune, and most common agent that is associated with this autoimmune is Campylobacter. Campylobacter is going to be cause this one. What is the condition associated, guys? This is ascending paralysis. Okay, this is ascending paralysis. Every body part is going to be involved in this patient can cause the condition, right? This is known as a GBS condition. Ascending flaccid paralysis will be seen. And there is question, what is the vaccine that is associated here? Influenza vaccine. Okay, influenza vaccine is also associated with the GBS. And also COVID-19, many patients are also associated with the GBS condition. Next, GBS condition is associated with the some of the important points. They are four types. One is Aman, okay, and other one here only the motor is involved. Next, other one is the Amsan, and motor and sensory both are involved. Next, AIDP, and this is going to be the demyelinating nerves of the involved. Next, the last type is the Miller-Fisher. Miller-Fisher is rare but very severe condition. Okay, AIDP is most common in India. And what are the antibodies here involved? Anti-GD1. And here also anti-GD1 is the most common. And most common in India, that is associated with the anti-GM1. Okay, anti-GM1. Severe Miller-Fisher will be associated with the anti-GQ1. Okay, these are the things that you have to remember. Next, diagnostic criteria, we have Britton's criteria. Britton's criteria we are going to follow for this patient. Next, what is the treatment of the choice, guys? IVIG. Okay, IVIG or the plasma exchange that we can use for this patient. Next, moving on to the another condition here, you can see this is the myotonic dystrophy. Okay, this is known as a myotonic dystrophy. So what is myotonic dystrophy? This is an autosomal dominant condition. What is the repetitions that is involved? CTG repeats. Okay, CTG repeats on the chromosome 19. Chromosome 19, there is a presentation of this condition. Basically, the patient will be associated with this kind of features. This phases is known as a Hatchet phases. This phases is known as a Hatchet phases. The most common symptom will be myotonia. The tone of the muscle will be decreased. The delayed muscle relaxation, which will cause the distal muscle easily weak. Okay, distal muscles will be weak. And cataract. So what is the cataract that is associated here, guys? Christmas tree. Right, Christmas tree cataract will be seen. And patient with cardiac defects will be also seen. And endocrine dysfunction will be also seen. And what is the investigation of the choice for this patient? Investigation of the choice for this patient will be genetic, and other one is the EMG. Okay, electronic myography can be also done for this patient. Next, this condition is known as a shortcut Mary tooth defect. Okay, shortcut Mary tooth disease. So this shortcut Mary tooth disease is also autosomal dominant condition. Autosomal dominant condition, again same here also, chromosome 17. Chromosome 17. And what is the gene that is involved? PMP22 gene that is involved here, guys. So here you can see there is a distal muscle wasting. Distal muscle wasting will be seen, and this is known as a Pes cavus. Okay, Pes cavus is seen in this patient. Next, also neural loss, so sensory neural loss. Sensory neural loss. Okay, sensory neural loss will be seen. Along with that the patient will be most commonly associated with the motor neuropathy. This is also genetic condition that will be seen. Next, coming to the another condition here, you can see what is this condition, guys? This condition is known as a Duchenne muscular dystrophy. Okay, Duchenne muscular dystrophy. And Duchenne muscular dystrophy is commonly seen as a genetic condition, especially X-linked recessive. This X-linked recessive is two types. One is Duchenne muscular dystrophy, another one is the Becker muscular dystrophy. So Duchenne muscular dystrophy, dystrophin is completely absent here, and here the dystrophin is mildly absent in this patient. So this condition is going to be severe, this is going to be moderate condition. So lifetime of this patient will be 25 years and average only, but here it can be 40 years also. Whatever the cardiac involvement, here the cardiac involvement will be more pronouncing, the cardiac involvement in this patient will be less likely to be. Okay, so the early death is also seen in the DMD patients. Next, what is the investigation of the choice, or we can say sensitive test? So sensitive test will be CKMM. Okay, the creatinine kinase of the muscle we are going to take from this patient, and how much it is going to be? 2500 times more in this patient. And what is the best test? Okay, gold standard is going to be biopsy, muscle biopsy, where the dystrophin will be destroyed in this patient. Next, treatment of the choice for this patient is Steroids we can give, and also IVIG can be given for this patient. And here you can see what is this sign, guys. This sign is known as a go over sign. Okay, so the patient is unable to get up by himself. That is known as a go over sign. Next, here we are going to discuss the another important person. Who is this person, guys? Stephen Hawking. So he is suffering from what disease? This is the disease which is known as a amyotrophic. So, okay, amyotrophic lateral sclerosis. Okay, so this condition is amyotrophic lateral sclerosis. So this is going to include upper motor neuron as well as lower motor neuron. So this will involve both the neurons. That's the most tragedy part of the this condition, right? Usually this is commonly seen due to degenerative condition. Okay, degenerative type of disease, and 90% of the cases will be sporadic. So we discussed yesterday what is meant by the sporadic. Very rarely that we are going to see. And another thing, the SOD gene, okay, the SOD gene, superoxide dismutase, and copper and zinc, that is involved in this amyotrophic lateral sclerosis genetic condition. Next, what are the things that is usually involved in this patient? First, anterior horny cells of the spinal cord will be involved here, and in the central nervous system, cortical fibers, and cranial nerve, cranial nerves nuclei will be also involved in this patients. Okay, so that's why the features of these patients will be asymmetric upper or unilateral movements will be decreased, or patient will be paralyzed. Over the time, the patient will be paralyzed. And continuous fasciculations, and these fasciculation can cause the cramps. Okay, this can cause the cramps. And also the DTR, the deep tendon reflexes will be exaggerated. So, okay, because it is combined with the upper motor and the lower motor. And which muscles are more involved, guys? Distal is more involved than the proximal. Next, there is a difference that you have to also know about the bulbar palsy of this one. First, it is going to involve the bulbar most commonly than the pseudobulbar. So what is this bulbar pseudobulbar palsy? Pseudobulbar is going to be due to upper motor neuron, and this bulbar is due to lower motor neuron. Okay, motor neuron disease is seen in this patient. So what are going to be involved here? Usually this is going to be cause the flaccidity. Okay, flaccidity will be seen in this patient. Next, here what happens? There will be a spasticity. Okay, there will be spasticity that will be present. So this is the difference between these two conditions. Next, what is the drug of the choice for this patient? Riluzole is the drug of the choice for the patient. Next, coming to the another condition that we are going to discuss now. So this is multiple sclerosis. Okay, multiple sclerosis we are going to discuss now. In the multiple sclerosis, this is the most common cause of the degenerative condition, especially myelin sheath of our brain. Next, other condition also you have to compare multiple sclerosis and also the Morg syndrome and neuromyelinating ophthalmitis is going to be the other condition. Okay, and what is the difference between these three? Usually it is going to involve the spinal cord, okay, less than 3, and it is going to involve the spinal more than 3 segments. Next, here also spinal which will be involved less than 3 segments. Next, neuritis, optic neuritis. So the most common cause of the optic neuritis will be myasthenia, multiple sclerosis, and it is unilateral. Here bilateral optic neuritis, and here also bilateral optic neuritis will be seen. Next, what are the antibodies that is present here? MBP antibodies that will be present in this patient. And here antibodies are AQP4 antibodies will be involved. And here mostly they are going to involve the myelin oligodendrocytes. Next, coming to the only multiple sclerosis. The multiple sclerosis is again autoimmune condition and chronic degenerative condition, right? So what happens? Usually these patients will be having the paralysis, okay, over the time that can cause the weakness, and that multiple nerves will be sclerosed, okay, the symptoms will be involved. Next, one of the things that you have to remember associated with this one is the phenomena. So they are having the Unth phenomena. Unth phenomena. What does mean by the Unth phenomena? Heat sensitive. They are heat sensitive and which will cause the aggravating symptoms. Next, Pullrich syndrome. Okay, Pullrich phenomena. So what is this mean by the Pullrich phenomena? The eye view, okay, eye view will be 2D or 3D. Without the glasses, they can see 2D or 3D. And what is the clinical criteria? Clinical criteria that we are going to use here, the McDonald's. Okay, McDonald criteria we are going to use in this patient. On MRI scan, you are going to see the dorsal finger appearances will be seen in this patient. On Ig globulins, if you see Ig globulins, you are going to see the oligoclonal antibodies which will be visible in this patient. Okay, next, what is the treatment? This is the autoimmune condition, so we can give the steroids for this patient. Right, this is the overview that you have to remember for the multiple sclerosis. So next we are going to discuss about the Huntington's chorea. So here you can see this is the condition of the Huntington's. So what happens in this Huntington's chorea? So this Huntington's chorea is also, okay, first see, Huntington chorea is mostly is also genetic condition. Autosomal dominant preferences will be seen in this patient. Next, there is a repetitions same as your myotonic dystrophy. The CAG repetitions on the chromosome 4 will be seen in this patient. So what happens? Usually chorea, right? The jerky movements will be seen in this patient, and also depression. The patient will be having the depression, and over the time on the chronic condition, there will be associated with the dementia. This is what's seen in this patient. And on the on the MRI scan, if you see, the patient will be having the this both lateral ventricles is going to be enlarged. Along with that, there will be atrophy. Okay, along with that, there will be atrophy of the caudate lobe and also putamen. The These condition will be associated here. Next, on the labs, if you see, there will be decreased of the GABA, and there will be also decreased of the glycine will be seen in this patient. Basically, it is a very fatal and progressive condition. The only treatment that we can do for this patient is we cannot do the genetic modifications, but we can do is the therapy. What is that therapy? Like supportive therapy to decrease the chorea and also to decrease the dementia of this patient. Next, moving on to the Parkinsonism. So in the Parkinsonism, the most commonly this Parkinson condition is associated in the old age people. Okay, more than 60 years of old patient will be having. If it is involved in the young patient, then it is going to be chromosome 4 or the chromosome 6. Okay, this is the PARK1 gene and this is the PARK2 gene, right? This is due to autosomal dominant. This is due to autosomal recessive. Next, what is the Parkinsonism condition? Basically, this is due to decreased dopamine, that will be present in the substantia nigra, which will be causing the degeneration. A degeneration will be seen in this patient, right? And also on the pathology slides, alpha-synuclein, and ubiquitin tau proteins will be seen on the pathology. These are those findings on the pathological sides of this patient. Basically, there is a decreased dopamine, and along with that, increased acetylcholine will be seen in this patient. What are the symptoms? Tremors, okay, such as resting tremor will be seen, and pill rolling tremors will be seen in this patient. There will be rigidity of the muscles. So this rigidity is known as a lead pipe rigidity in the chronic, or we can also say the cogwheel rigidity, right? Echinacea and the gait abnormalities is also seen in this patient. All these conditions most commonly and over the time it can also lead to the dementia. That is a common thing that we are going to see. Next, what is the treatment of the choice for this patient? The drug of the choice for this patient is a levodopa, which will be increasing the dopamine agonist, right? Along with that, we can also give carbidopa. Okay, carbidopa, because this carbidopa is going to manage, and both the combination is going to be give the excellent prognosis for this patient. Next, coming to the Alzheimer, this is the Alzheimer's condition. So what happens in the Alzheimer condition? This is the most commonly seen in the dementia types. Okay, this is the most common dementia type. So these are known as a beta amyloids. So most commonly associated with the beta amyloids in the patient. And if it is involved, it is due to chromosome 21 involvement. And also neurofibrillary tangles will be also seen in this patient, right? Over the time, the cortical and hippocampus atrophy will be also seen in this patient. And the dementia is most commonly due to decreased acetylcholine, whereas in the Parkinson's, the acetylcholine is increased in this patient, right? Next, other factors also you can remember, like ApoE3, like ApoE4, sorry, ApoE4 deficiency, and also chromosome 21, so Down syndrome patients, and over the time age, illiteracy will be including in this patient. The patient will be having most commonly memory loss and gait changes, and also language difficulties, visual disturbances, all will be seen in this patient, right? This is what we're going to see. Next, coming to the treatment of this patient, we are going to give the cholinesterase inhibitors to decrease the cholinesterase activity, so that acetylcholine will be increased, right? So what is the common drug? That is donepezil is a drug of the choice for this patient. Other drugs we can give memantine. This memantine is going to be NMDA antagonist. This is antagonist, right? These are the important things that you have to remember from the neurology topic, guys. Next, moving on to the hematology. In the hematology, here you can see these are the important points, guys. First, what are the types of anemia? First, you have to get the hemoglobin, and hemoglobin, if it is less than 7, this is severe already. Okay, so if it is less than 10 also, you have to get the investigations done. First, if it is microcytic or the macrocytic. Let's see, microcytic, the example is thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning. If it is macrocytic, most commonly folate deficiency or the vitamin B12 deficiency. Okay, that too you have to remember, or liver disease commonly. Next, normocytic anemia. The normocytic anemia can be non-hemolytic or the hemolytic. Non-hemolytic, such as iron deficiency anemia, anemia of the chronic disease, or the aplastic anemia, or the acute blood loss. Next, if it is hemolytic, hemolysis, that means something is killing the RBC. It could be due to membrane defects such as hereditary spherocytosis, or it is due to paroxysmal nocturnal hemoglobinuria, or the G6PD deficiency, sickle cell anemia. Next, if it is not the intrinsic factors, then something coming from the outside, like antibodies producing. What are those antibodies producing? Autoimmune and microangiopathies, or the infections that is causing here, right? This is the differentiation between the all types of the anemia that you have to remember. Next, here in this slide, you can see the pictures. Let's see, let's go through by one. So first, here you can see these cells are known as a acanthocytes. These cells is known as a acanthocyte. Seen in which condition, guys? Liver disease. Okay, commonly seen in the liver disease patients that we are going to see. Next, another one here you can see this is known as a echinocytes. Okay, this is known as a echinocytes, and echinocytes is usually seen in the end stage renal disease and also end stage liver disease patient we are going to see. Next, here these are known as a teardrop cells. This is known as a teardrop cells, also known as a dacrocytes. Okay, they usually seen in the very rare conditions, rarely seen in the myelofibrosis. Okay, myelofibrosis condition, we are going to see this condition. Next, this one is known as a helmet cells. also called as a cystocytes, seen in which patients, guys? Usually autoimmune hemolytic anemia. In this patient, we are going to see such as DIC, like diffused, diffused disseminated immunogenic. It is also seen in the patients of the DIC and HELP syndrome in the pregnancy that we are going to see in this condition. Next here, this is known as a bite cells. Bite cells plus helmet cells seen in which condition? Hens bodies. Okay, hens bodies. All these seen in which condition, guys? G6PD condition. We are going to see this one, right? Next, coming to the elliptocytes. This is known as a elliptocytes. So elliptocytes are seen in the hereditary form only. Okay. Another type of the hereditary condition. We are going to see this condition. Next, these are the spirocytes. Okay, these are known as a spirocytes, commonly seen in the hemolytic anemia and hereditary spirocytosis. This is macro. Okay, this is known as a macro type seen in the megaloblastic anemia such as B12 deficiency or the B9 deficiency. These are target cells. Okay, these are the target cells seen in the thalassemia, most commonly, or patients those who are suffering from the asplenia condition. Next, this is the sickle cells. These are the sickle cells seen in which condition, guys? Commonly sickle cell anemia. Right, these points that you have to remember. Next, another picture that you have to take note, what are the other important cells that will be seen. Okay, first, whenever I say the Howell Jolly bodies, okay, Howell Jolly bodies, these Howell Jolly bodies are seen in the patients of the sickle cell anemia. Next, basophilic stippling. Basophilic stippling. This is seen in the patients of the sideroblastic. This is seen in the sideroblastic and also lead poisoning patients we are going to see. Next, Pappenhammer bodies. Okay, Pappenhammer bodies. These are seen in the, again, sideroblastic anemia. Okay, sideroblastic anemia, we are going to see these types of the different types of cells that we are going to see. Next, important points, what else you can remember from this picture? Other types that you have to recall is what is the difference. Okay, first here you can see iron deficiency anemia and sideroblastic anemia, anemia of chronic disease. In this patient's iron profile, if you have done, what are the values? So iron deficiency anemia, iron will be decreased. Sideroblastic anemia not related to the iron, so iron will be increased. Anemia of chronic disease, over the time this condition is going to decrease. Next, ferritin. So ferritin is also decreased in the iron deficiency anemia, and in the sideroblastic anemia it is going to decrease, and same as the anemia chronic disease also. Next, TIBC, this is going to be increased in the patient because the capacity of the TIBC is increased due to decreased ferritin. So here it is going to be decreased, same as here it is going to decrease. Next, T percentage, the transferrin percentage is going to decrease in the iron deficiency anemia and increase in the sideroblastic anemia, and here also it is going to increase. So only difference that you have to remember, iron deficiency anemia TIBC increase, sideroblastic anemia TIBC will be decreased. That's the one finding that you have to remember, and these are the some of the findings also you have to recall, guys. Right, next, moving on to the another important points that you have to take note when you are reading these conditions. Right, leukemias. Okay, let's learn about the leukemias. So we have the acute types: acute lymphoid leukemia, acute myeloid leukemia. First, we will see the acute leukemia and acute myeloid leukemia. First, see the difference between this. Most commonly seen in the less than 10 years of the age, and this is seen in the more than 15 years of the age, up to 40s also. Next, this patient, what are involved? Basically, they are going to be involved the central. So lymphoid will be central. So in the CNS and also lymph nodes, okay, and testis, this will be commonly involved. Next, AML myeloid, so surroundings. So this is going to involve the patient's gum bleedings, okay, gum bleedings, and also such as chloroma, DIC will be also involved. Next, what are the percentage that you are going to see on the peripheral blood smear? At least equal to 20% of the blast cells of the lymphoid we are going to see. Same as here also. Blast cells that we are going to see. Next, what is the stain? Here, periodic acidic fast stain we are going to be positive, and here myeloperoxidase and oil red, that is positive in this patient. Next, markers in this patient: CD1, 2, 5, 7, and also CD 19 and 10 is positive here. Here, the CD 13 and 33 is going to be positive. These are also going to be important points that you have to remember, guys. Next, ALL is, don't have to remember about the what are the involvements of the translocations, but here you have to remember some of the translocations like 8 and 21 and translocation 15 and 17. Okay, these are the important for the translocations of the acute myeloid leukemia. Next, coming to the difference between the CLL and CML. Okay, CLL and the CML. Most commonly, these both are seen in the elder patients only. Okay, next, these patients associated with the massive splenomegaly. Massive splenomegaly that we are going to see. Next, here this patient will be again acute hemolytic anemia, lymphadenopathy will be seen, right? On the peripheral blood smear, you are going to see the smudge cells, that is positive. And here basophils is going to be positive. Next, CD5, CD200 is positive. So in this patient, again, MPO is going to be positive. Next, when it comes to the trisomies, trisomy 12 is going to be involved here, and here translocation 9 and 22 is involved in this patient. Right? This is the points that you have to remember. Next, coming to the Hodgkin lymphoma. Okay. Next, coming to the Hodgkin lymphoma. In the Hodgkin lymphoma, we have to take note which are the different types. Only one, what is associated with which type. Okay, that is the first thing that you have to take note. First, let's see what is the most common type in India. In the India, the most common type is the mixed cellularity. Okay, and what is most commonly associated with the HIV condition? That is lymphocyte, that is lymphocyte type of Hodgkin lymphoma is most commonly seen. Next, what is associated with the Restenberg cells? Restenberg cell will be seen in all types of the type, but these Restenberg cells will be seen as lacunar. Okay, it is seen as a lacunar in the nodular sclerosis Hodgkin lymphoma, and it is seen as a eosinophilic type. It is also seen as a eosinophilic type that is seen in the again mixed cellularity Hodgkin lymphoma, and mononuclear type. Okay, mononuclear type that is seen in the lymphocytic rich Hodgkin lymphoma. Right, these are the some of the types. And next, pleomorphic that is seen in the patients of the lymphocyte depleted Hodgkin lymphoma. Popcorn type, we also have the popcorn type, and this is seen in the lymphocytic predominant type of the Hodgkin lymphoma, which is very non-classical type. Next, what are the excellent prognosis? So here, so this lacunar is a good prognosis. Okay, next, what are the poor prognosis? P for pleomorphic, P for poor prognosis, or the lymphocytic dominant depleted type of the prognosis will be also very poor. Next, Epstein-Barr virus. Epstein-Barr virus will be associated with all types, okay, except this one. So, okay, Epstein-Barr virus will be absent in this patient. Along with this here also, Epstein-Barr virus will be absent. These are the points that you have to take note. Next, starry sky appearance. Starry sky appearance are seen in the Burkitt lymphoma. Okay, Burkitt lymphoma. These are the important points that you can remember for the hematology topic. So now we are going to discuss about the endocrinology, guys. In the endocrinology, you all know that we have the multiple glands, right? All these endocrine glands is going to produce the specific hormones, right? For example, pineal gland is going to produce the melatonin, right? Pituitary glands is going to produce the growth hormone. Thyroid is going to be produced by the thyroid hormone and also parathyroid hormone. Right, next, pancreas is going to produce the glucagon and insulin. Adrenal glands is going to produce the aldosterone and catecholamines, and also androgens is going to be produced here. Ovaries, GnRH, and also going to LH and FSH is going to be produced here. Next, placenta is going to produce the lactogen and other important hormones will be produced here. So let's see what is the diseases that is produced by the these conditions of the endocrine. So first we are going to see the prolactinoma, right? The conditions first we are going to discuss here is the prolactinoma. In the condition of the prolactinoma is basically due to the tumor. What is that most common cause? Is due to pituitary adenoma. Why it is due to pituitary adenoma, or nowadays it could be iatrogenic. Okay, iatrogenic means due to drug abuse. Okay, taking the metoclopramide or other agents which is increasing, that can cause this condition. Next, when it is comes to the symptoms, this patient is going to have specifically milk discharge, which is also known as a galactorrhea. This is commonly seen in these patients, and also libido changes will be seen. So like decreased libido will be seen in these patients. If it is a males, most commonly seen. Next, in the females, menstrual changes will be seen, right? These are also going to be seen in this condition, and it is near the optic chiasm, right? So these optic chiasm can also cause the visual disturbances. So if the tumor is compressing the optic nerve, then it is going to cause the patient or disturbances for the vision. So on the neuro-ophthalmology specific finding that you are going to see, that condition is known as a bitemporal hemiamnopia. Okay, bitemporal hemiamnopia is seen in this patient. Right, next, coming to the what is the screening test, what is the investigation of choice. So the screening test for this patient is visual field test. So this test will help us is the tumor is micro or the macro. So investigation of the choice, if they have positive screening, then we have to proceed for the MRI pituitary cut. Okay, MRI specifically only for the pituitary cuts we have to investigate. Next, treatment, if it is a macro and compressing with the visual defects, then you have to proceed for the surgery for this patient. If it is a micro, then you have to go for the drugs. So what are the common drugs we are going to use? The drug of the choice for this patient is cabergoline. Okay, cabergoline is given. Or other drug will be commonly used, bromocriptine. This can be also used in this patient. Next, moving on to the acromegaly. So here you can see acromegaly. This is most commonly associated with the growth hormone. Okay, excessive growth hormone condition. And most commonly, this is also due to adenoma or the hyperplasia. Okay, most commonly pituitary adenoma only. So what happens when the growth hormone is excessively producing? Growth hormone will release the IGF. What is this IGF? Insulin-like growth factor. So if this insulin-like growth factor will release into the body, so automatically the insulin, the real insulin will be decreased, and there will be increased sodium absorption and H2O production, right? And what is the triad that is commonly associated in this patient? So blood pressure is going to increase, diabetes mellitus is going to cause, and organomegaly, right? Organomegaly will be seen in this patient. This is the classic triad that we are going to present in this patient. And they also associated with the increased risk for the colon polyps in this patients. Next, what is the screening test for this patient? For the screening test, you can go for testing the IGF serum levels. Okay, and investigation of the choice will be OGTT, and OGTT positive will be more than 300 milligrams. It is going to be positive for this patient. Next, treatment and drug of the choice for this patient is the octreotide. Okay, octreotide, or we can also give the stomatostatin antagonist. Drug can be also given for this patient, right? Next, what are the features? Here you can see there will be a facial enhanced acromegaly. So this is the patient. Okay, and brow and enlargement of the base of the nose, thickening of the nasolabial sulcus, parotid hypertrophy, enlarged hands, are the one of the celebrity Great Kali is having this condition. Next, moving on to the SIADH and diabetic insipidus. Let's see the SIADH, guys. So what happens in the SIADH? This is due to syndrome of inappropriate increased ADH. Okay, increased ADH. So what is the normal function of the ADH? It has to retain the water. So it will going to retain water, right? And how much? So it will become the hypervolemia. Okay, more volume is going to be overloaded in this patient. And when it is going to increase, it is also going to increase the cardiac output. So further will cause the blood pressure is increased. So when the blood pressure is increased, this is going to stretch the heart, right? So when the heart is stretched, it is going to produce the ANP. What is this ANP, guys? Anti-natriuretic peptide. Okay, anti-natriuretic peptide will be opening. So these anti-natriuretic peptide will cause the sodium plus H2O excretion. Okay, from the body it is going to excrete. So at this point we are going to have the hypovolemia. Okay, hypovolemia is seen in this patient. And hypovolemia, once again it is decreased, it is going to again increase the ADH, which will eventually balance our body with the euvolemia status. So at a time you have seen the hypervolemia, hypovolemia and the euvolemia due to inappropriate increase of the ADH. Next, in this patient, the most common cause for this condition is lung cancer. That is why paraneoplastic syndrome or the carcinoma that is associated with this conditions. Next, what is the diagnostic test that we can perform? Water loading test. Okay, water loading test is going to be positive in this patient. What is the drug of the choice? Whichever the drug that is ends with Vaptons is going to be given for this patient. This Vaptons is going to block the ADH. That is the drug of the choice we can give for this patient. Next, another condition, DI. DI means this is diabetic insipidus. Okay, diabetes insipidus. So diabetic insipidus is two types. One is central, that means it is present in the central, means it is in the pituitary. Okay, next, other is the peripheral type. So peripheral ADH is present where, guys? In the kidney. Okay, so first, where is the ADH is coming? So it is coming from the pituitary, and then it is going to act on the kidneys, right? And then it is going to act on the blood vessels, right? This is how normally ADH works. So central diabetic insipidus. So the defect is in the pituitary only. So ADH is not producing. So that patients will be associated with this condition. Okay. Next, peripheral. So here peripheral also it is coming from the pituitary, then it is going to present in the kidneys, then blood vessels, right? This is the pattern. What happened here? Pituitary is normal, but kidneys are dysfunctional. So it is the problem is in the kidneys. So how can you check if the ADH is normal? Then it is the not the pituitary cause. If the ADH completely deficient, then it is the central cause. So for this patient, drug of the choice for this patient is the desmopressin, which is also known as a vasopressin, artificial type of the ADH. Next, in this patient, the drug of the choice is the thiazides because the defect is present in the kidneys, right? Next, investigation of the choice for this patient is the water deprivation. Okay, water deprivation is the drug of the choice, sorry, investigation of the choice for this patient. Next, moving on to the adrenal glands and their associated conditions. Let's see first what is the adrenal gland. Adrenal gland is divided as a medulla and cortex. So medulla is going to produce the catecholamines. Okay, all the catecholamine hormones are epinephrine and the norepinephrine. Next, we have the cortex here. Cortex have the three zones. The outermost is the glomerulosa, which will be producing the mineralocorticoids and aldosterone. Fasciculata is the middle one, glucocorticoids, cortisol and the cortisone. And reticularis is going to produce the androgens, testosterone and the estrogen. Okay. Next, what is the disease that is associated with the medulla, guys? That is pheochromocytoma. Okay. It is the condition pheochromocytoma. So these pheochromocytoma will cause the increased epinephrine and increased norepinephrine. So catecholamines are going to be secreted high in this patient, and this is the most common benign tumor in the suprarenal gland. Okay, next, this is going to follow the rule of 10. So what is this rule of 10, guys? So 10% of the cases will be bilateral pheochromocytoma will be seen, and 10% it's actually benign. 10% of the patient will be associated with the malignant, and only 10% of the patient or 10% of the population will be associated with this condition. 10% this benign tumor, not just in the adrenal, it can be also associated with the extra-adrenal sites for the tumor production. That is what rule of 10. Okay. Next, what is the symptoms that is present in this patient? Basically, the patient will be associated with the headache because the catecholamines are very high in pressure. Next, catecholamines can also increase the hypertension crisis and also palpitations. So these are the classic symptoms that will be present in this patient, and these symptoms are going to be recurrent and resistant, right? That is why we have to going to investigate this patient with the urinary assay. So in the urinary assay, we are going to check the metanephrine levels. Okay, if the metanephrine levels are high, then the condition is positive. Next, drug of the choice for this patient is surgical excision. Okay, surgical excision. In the surgical, you have to manage. First, you are going to use the rule ABC. First, you are going to start the patient on the alpha drugs, then beta blockers, then go for the cure. Okay, first initially you are going to start this alpha agonist, then the beta blockers, followed by the cure of the surgery. Next, moving on to the other adrenal disorders. First, we are going to see here Cons syndrome. Okay, Cons syndrome, the most common cause will be adenoma. Okay, the adrenal adenoma is going to cause this condition. Next, what happens in the Cons syndrome? When the Cons syndrome is affected, it is going to increase the aldosterone. Okay, if the aldosterone is increased, what it is going to do? What is the normal function of the aldosterone, guys? Let's see here. So this is the aldosterone. So what does the aldosterone will do? It will going to cause the vasoconstriction. It is going to cause the vasoconstriction. By what mechanism? It is going to have the ENaC channels. These are the ENaC channel, epithelial sodium channels. So it is going to get the sodium and also water. So further, it is going to increase the blood pressure and decrease the potassium outside. Okay, potassium efflux will be seen in this patient. So the BP will be managed with the vasoconstriction and also sodium inside. This is what aldosterone normal mechanism. So if the aldosterone is producing continuously, it is going to cause what? It is going to increase the sodium and along with that decrease the potassium because it has to efflux. So also the sodium will carry the water and potassium will carry the H plus ions. So what are the symptoms, guys? This patient is going to present with the hypertension. Then there is increased sodium levels will be seen and also decreased potassium levels, and H plus ions are gone out. Next, metabolic alkalosis will be seen in this patient. These are the symptoms, classical symptoms that is going to present in the Cons syndrome. Next, investigation of the choice. So the patients will be having the saline infusion test positive. Saline infusion test is positive. Next, treatment is spironolactone because the spironolactone is epithelial channel blocker. So that is why we have to go for the spironolactone drug. Next, moving on to this is the another condition that is known as a Addison's disease. Okay, this is known as a Addison's condition. In the Addison's condition, the complete adrenal shutdown. Okay, not just one hormone, complete adrenal shutdown is seen in the Addison's condition. So that means the patient aldosterone is completely not working and cortisol, okay, cortisol is not working and also androgens, and even inside the catecholamines that is also not working in this patient, right? So this is the effect of the Addison's, complete hypoaldosteronism we are going to see in this patient. What happens? Basically there will be increased hypokalemia. right? Because opposite mechanism, if the sodium is going to be decreased here, so sorry, hyperkalemia, guys. So opposite effect, there will be hyperkalemia and hyponatremia will be seen in this patient, right? And also blood pressure will be decreased, hypotension will be seen, androgens are low, then the patient will be having the libido changes and menses changes will be seen, and cortisol is decreased, then the patient will be having the hypoglycemia, right? Catecholamines are decreased, then again BP will be seen in this patient, and metabolic acidosis will be seen because H plus ions is going to be increased. These are the symptoms. But what is the most common cause? The most common cause will be HIV in the worldwide. Okay, but in India, the most common cause is the TB. Right, these are the causes. Investigation of the choice for this patient is the ACTH stimulation test. ACTH stimulation test, and drug of the choice for this patient is the hydrocortisone. Emergency drug hydrocortisone should be given for this patient. Next, here comes the Cushing's disease. Okay, Cushing's syndrome. Cushing's syndrome, the most common cause will be iatrogenic. If it is a Cushing disease, this is due to pituitary. Okay, this is due to pituitary. That is the one of the thing that you have to remember. Next, what is the effects that you are going to see? Excessive hair growth and also osteoporosis, adrenal hypoplasia, amenorrhea, obesity, central obesity, olaceous stria like this stria, and muscle loss, easy bruising, moon phases. This is known as a moon phases, and fat. This abdomen backside fat will be seen. These are the symptoms of the Cushing syndrome. Next, investigation of the choice for this patient is the dexamethasone suppression test. Okay, dexamethasone suppression test. So already the cortisol will be increased in this patient. So you have to taper the using of the steroids, and over the time you have to stop and withdraw this particular drug. And if it is associated with the pituitary tumor, then you have to do the excision for that patient. Right. Next, moving on to the parathyroid hormone. So here you can see these are the four lobes of the parathyroid hormone on backside of the thyroid gland you are going to see. What is the normal mechanism of the parathyroid hormone? When the parathyroid hormone is normal, so it is going to maintain the calcium homeostasis. Calcium homeostasis it is going to maintain. But when parathyroid hormone is increased, why? When the triggering factor is calcium is decreased. So to increase the calcium, what is the main role that the parathyroid hormone is going to do? First, it is going to act on the bones. So from the bones, it is going to cause the osteoclast action. Okay, osteoclast. So where the bone resorption, it will increase the calcium. Next, it is going to move to the kidneys. Okay, where in the kidneys, again, reabsorption will be seen. So reabsorption will be seen. Again, the calcium levels will be increased. Then moving on to the GIT. Okay, GIT system. Again, there will be a calcium intake from us, and calcium will be reabsorbed. And all these mechanisms is going to increase the calcium in our body. So this is how calcium metabolism will be maintained. Next, we have the two different diseases from the parathyroid hormone. So one is primary hyperparathyroidism, and secondary hyperparathyroidism that we are going to see. So what is the main difference between these two? So primary is most commonly due to adenoma, okay, pituitary, or it is most commonly due to parathyroid adenoma only. Okay, in this patient, when you check, parathyroid hormone will be increased and also calcium is increased. Then phosphorus is going to be decreased. Okay, phosphorus is going to be decreased in this patient. Next, those who are suffering from the hyperparathyroidism, most commonly due to kidney CKD. So in this patient, parathyroid hormone will be decreased, calcium will be decreased, and phosphorus will be increased. So these are the changes that you are going to observe in the primary versus secondary parathyroid hormone. Next, here you can see this is the normal mechanism of the thyroid. So this is the normal mechanism of the thyroid metabolism, guys. How it is happening? Let's see. The first event of this first event will be thyroglobulin. Okay, the thyroglobulin is produced in the follicles of the thyroid. So what else it is needing? Iodine. Okay, so once this iodine is going to enter into the follicular cell, this is going to start its process with the help of what enzyme? Here it is. The peroxidase enzyme is going to help it. So once this iodine and thyroglobulin is going to match, so that will be causing the coupling reaction. So this coupling reaction is also due to peroxidase. So these peroxidase is going to play the major role in the thyroid metabolism. Once they are going to form, it is going to form the monoiodothyrosin, and another one is the diiodothyrosin, and then they are going to form the T4 and T3. Once they are formed, come back to the follicular cells and they are going to send into the circulation. So this is the normal mechanism of the thyroid gland that we are going to see. Okay, next, see what disease that is associated with the thyroid gland. First, before that, we have to understand what is the mechanism of the thyroid gland. First, the thyroid releasing hormone from the hypothalamus will stimulate the thyroid stimulating hormone. Then it is going to produce the T3 and T4. This is how, right? And if the T3, T4 is normal, then it is going to send, please stop. This is the negative mechanism. And then it is going to send again signal back, negative feedback mechanism. Please stop, that we are already normal. This is one mechanism. But in the diseases patient, how can we interpret this? First, let's see the differences, guys. First, we are going to proceed for the primary hypothyroidism. So we are going to investigate in this patient first TSH, which is the major role, and T3 and T4. Okay. So in this patient, what happens? The primary hypothyroidism patients usually negative feedback mechanism. That means T3, T4 is decreased here. So it will send that you have to increase so that production will be normalized. Right? This is how primary. Next, secondary hypothyroidism. So in the secondary hypothyroidism, the TSH will realize, yes, something is wrong with the T3, T4. So it is going to be decreased. Next, primary hyperthyroidism. Okay, again negative feedback mechanism. Already the T3, T4 is high, then TSH is going to decrease. Secondary hyperthyroidism, so the both is going to be increased here. So these are the mechanisms that you have to remember. Next, we also have the subclinical hypo and subclinical hyper. So what is this subclinical hypo, guys? Subclinical hypo, the T3, T4 is normal in both. Okay. And in subclinical, again, hypo. So that means if it is normal also, it is going to be increased. Hyper, it is going to be decreased. So this is how the laboratory interpretation should be done for this patient. Next, here comes another important points about the what is the most common. The most common cause of the hyperthyroidism is going to be Hashimoto's. And the most common here is the Graves' disease. What are the features for the Hashimoto's? The puffy face, enlarged thyroid, which is known as a goiter, slow heart rate, constipation, and high infertility, heavy menstruation. These are seen. Why? Because the basal metabolic rate that is decreased. And here the basal metabolic rate is increased. So fine and brittle hair loss, increased sweating, nausea and diarrhea. Again, weight loss will be seen in this patient, and abdominal heart as a abdominal abnormal heart rhythms, enlarged goiter, tremors, because all is due to basal metabolic rate is increased. What are the antibodies that is associated with the Hashimoto's? TPO, thyroid peroxidase antibodies is going to be positive, or thyroglobulin antibodies is positive. When it is comes to the most common in the Graves disease, iodine receptors and also TSH receptors. TSH receptors is going to be positive. Next, what is this condition, guys? We discussed in the orthopedics. This is known as a brown tumors seen in the parathyroidism. Okay. So these are the important factors that you have to remember. Next, coming to the another condition, GIT. We are going to close with the GIT. So first, we will discuss the hepatitis conditions, guys. So basically, the most common is the viral hepatitis, right? So in the viral hepatitis, we will see what are the types of hepatitis is present. First, hepatitis A and hepatitis B, hepatitis C, hepatitis D, and hepatitis E. Right? Total 5 types we have as a hepatitis viruses. So What are the important features of them? All are going to be RNA except DNA. So this is going to be the DNA double stranded. Remaining all are RNA only. Okay. Next, all are going to be enveloped except A, that is naked. Okay, this is also naked. Remaining all are enveloped. Next, what is the incubation period? Incubation period is less than 30 days. And these patients 180 days. Again 180 day and 60 days to 100 days. And this is going to be less than 30 days. Okay, what is the transmission route? So the transmission route is basically fecal-oral, hepatitis A and also hepatitis E. So this is also fecal-oral route. Next, BCD is going to be most commonly from the blood transfusion. Here also it is due to blood transfusion. STDs, right? STDs can be seen here also, blood transfusion and STD. Okay, and also vertical from mother to baby. Here also vertical transmission is seen. Next, coming to the cancer, hepatocellular carcinoma, absolutely not seen here. Hepatocellular carcinoma not seen, and hepatocellular carcinoma is associated here, and hepatocellular carcinoma is 2 times associated in the hepatitis C, and here it is associated with the super infection. Okay, this is associated with the super infection. One or other hepatitis B or C will be associated. Next, chronicity. So the chronic is condition is not seen in the hepatitis A, and same as here. Chronic is not seen. So here the chronic will be seen, and here 2 times chronic will be seen. And again, this is super infection associated hepatitis D. And overall, what is the most common? Overall, most common is hepatitis E. And super infection D plus B, then it is a super infection. And if it is a senior, only pregnancy patient involved, so most common in pregnancy is E. But most severe in pregnancy is E. Okay, these are the points that you have to remember. Now we will see hepatitis B. Hepatitis B, their antigens. Okay, their antigens and antibodies. So first hepatitis, what are the antigens that is present? So the first antigen is the HBsAg. Okay, so this is the first antigens to get positive in the body. Next, second one is the HBeAg antigens. This is going to produce the active infection, and this period is going to be infective. Okay, highly infective, and also replicity that is going to present in this patient, that is associated with the HBeAg. Next, what are the antibodies that is going to produced by the hepatitis B, guys? So antibodies such as we have the anti-HBs, anti-HBC antibodies. Either it is going to be associated with the IgM, which means acute, and IgG, then it is chronic. Right? Next, anti-HBe antibodies is likely to be that it is in active condition, and infectivity this period is also be less. Next, anti-HBs antibodies. That means that the patient is already cured or that the patient is vaccinated. So this is how we are going to interpret. Let's see some of the examples here. Okay, 2 examples we will see. First, what I was telling is HBsAg positive, HBsAg positive, and HBe antigen is also positive. So that means that the patient is going to be what you have to interpret, guys. What I said, this is likely to be that the patient is infective, right? The replication is also positive here. So that the patient is hepatitis positive with highly infective, likely to be this is IgM acute infection. Okay, next other patient we have. Other patient scenario like here also HBsAg positive. Okay, next anti-HBe positive. These are the antibodies. That means the patient is low infective, already must be chronic, right? Chronic hepatitis B positive. That is how we are going to interpret. Next, from this graph, you don't have to remember the entire thing, but here you can see the only antigen that is positive throughout the year of the infection, that is HBeAg, and anti-HBe is going to be positive. And which is very shorter, anti-HBs is going to be shorter. HBs antigen is also going to be positive for throughout the life. Next, we are going to see some of the important conditions of the GI can be asked in the examination. First, this is the Whipple's disease. Whipple's disease is going to be caused by the Triporema whippleri. This is a bacterial condition, guys. So this is associated with the bacteria. Okay, what it is going to be caused? Most commonly, the patients with the Whipple's disease having the specific triad, that is malabsorption. Okay, malabsorption, and it is going to involve the knees, arthritis can be, or arthralgia, and also CNS like dementia will be also seen in this patient. So this is the classic triad for this patient. So if they are associated with the dementia, then this patient condition will be poor prognosis. Most commonly seen in which patients? Usually more than 50 years of old patients, and males is most commonly associated which condition. Next, on the histopathology, it is going to see as a foamy macrophages. Foamy macrophages pass positive will be seen. Drug of the choice. What is the drug of the choice? IV ceftriaxone should be given. IV ceftriaxone should be given for at least 14 days. Okay, next, tropical sprue. So in the patients of the tropical sprue, this is post-infectious. Okay, this is post-infectious. Commonly associated is E. coli. Whatever the GI in microbiota like E. coli can be caused. And first it is going to involve the small intestine. Okay, then it is going to cause the pan intestine. Okay, once it is involved small intestine, then it will cause the pan-intestinal infection. And over the time, when this is involved, it will cause the inflammation. It is going to trigger the inflammation and further cause the villus atrophy. And once it is involved, all right, so iron deficiency anemia will be seen, B9 deficiency is seen, and B12 and many other micro or the macro nutrients will be decreased in this patient. So the treatment is for this patient again post infectious, so tetracycline should be given as a drug of the choice, and then we can give whatever the deficiencies, vitamin supply has to be given for this patient. Next, coming to the other condition, here you can see this condition is known as a celiac disease. And what is this picture, guys? This is dermatitis herpetiformis. Okay, dermatitis herpetiformis. So this common condition is seen with celiac disease people, right? That is one of the symptoms that you have to see. Next, celiac disease is most commonly, it is an autoimmune condition and self-destructive due to gluten hypersensitivity. Okay, it is only hypersensitive to gluten. So this patient will be producing what most commonly they are associated with the HLA-DQ2 antibodies, and these are going to be the genetic association. Next, most sensitive antibodies, if you see in their serum test, that will be anti IgA anti TTG antibodies will be present in this patient. Whereas the biopsy is going to be gold standard. Biopsy is gold standard for the test. On the biopsy, you are going to see the villus atrophy, and also Cripps hyperplasia will be seen in this patient. Right, this is how we are going to present. What is the treatment? Gluten hypersensitivity, right? Please avoid the gluten. Okay, so what are the gluten? Barley should be avoided, rye and wheat. So this is oats, but oats are less associated. These three should be avoided for this patient, right? So this is the most important discussion of the neurology, endocrinology. Please do revise these topics, guys. Very important for your examination. And those who are new to this channel, please do subscribe and also stay tuned for the short topics from the 10th January. So until then, see you guys. Happy preparation.